All right. Hi, everybody. We're going to go ahead and get started. We have a wonderful didactic prepared for today, and I want to make sure we address all questions. As you guys have definitely gotten used to, keep chatting us your name and information so we can record you for CME. And any questions, definitely chat those in. And Lisa is going to be giving us the didactic today, which is super exciting. Lisa has been with us since we started this COVID echo, so everybody's gotten used to seeing her, and I'm super happy to hear you talk today. But Dr. Hodder, I was going to give you some time right now to say anything you need to.
Well, I just want to thank everyone again for joining, and a special thanks to Lisa. As everybody knows, Dr. Costello is an assistant professor in pediatrics, but she has really been working very closely with the Bureau of Public Health and is going to bring to us updates. Coronavirus, everything changes almost every week. And so we're really delighted to have her bring us the latest from the state. So Lisa?
Well, thank you so much, Dr. Hodder, and thank you to the entire ECHO team. I think these COVID-focused ECHOs have really brought a lot to our state and to me personally, and also as something to refer back to. I frequently go back to past ECHO sessions on the YouTube channel and look at different things that were discussed, but things are certainly rapidly changing, and we'll hope to be able to share new information with you and then take questions, as well as using the collective wisdom of other people on the phone and on the chat, as well as the Zoom. So Caitlin, if you want to go ahead and bring up my slides, I think we can jump right in and then make sure that we answer any questions as well. So I thought I would, give an update of where we're at, as I think moving forward, we're going to be spacing out our COVID-focused echoes. There's still certainly a lot of changes happening, including this morning, since since I submitted this slide deck. So I think that we have to continue to make a concerted effort to stay updated with information that is coming. And also, as I think every speaker has stated when giving a talk on COVID, this is subject to change. This is information that we have based upon what we know now, but within a couple days, weeks, sometimes some hours, things could change. So if you go ahead to the next slide, I don't have anything to disclose, and we'll move right along to the next one, where this is just kind of the three areas I wanted to touch on, and then really leave a majority of time to answer question, and then also to, I think, open up dialogue, I guess, as well, to maybe hear what's, questions happening in the community and what we're seeing as we enter into this next phase of our kind of pandemic response. So we'll talk about the comeback. We're going to focus a little bit on testing, and then I do want to give an update on Remdesivir, which is some exciting developments that we have there, and certainly has been very busy this week on that topic. So if you go ahead to the next slide. So this is sharing some information from the governor. So West Virginia Strong, the comeback is the effort that we are in now. This information is available on the West Virginia governor website, and I encourage individuals to frequently check back there to get information surrounding the comeback plan and recovery efforts. If you go on to the next slide, this is kind of the roadmap that was laid out, and we're going to talk about some specific areas within this roadmap moving forward. But really, to kind of be able to open back up in West Virginia, because we've done a good job as a state and leading efforts to keep our numbers low, or kind of keep our curve flat. And so part of moving forward is that we really need to expand testing capacity. We're doing this in a variety of means. We've talked about testing in some shape or form, probably on every ECHO. We've talked about different testing coming down the pipe. So when we talk about antibody testing and then also antigen testing is now being brought into the discussion. At this moment, the most testing that's being performed is still PCR based, and we're seeing that capacity increase across the board at both facilities and from commercial vendors. And then also part of the roadmap is increasing hospital surge capacity, but allowing elective medical procedures to restart. And so this was a slide back from when he announced it, which was on April 27th. So we do know that there are elective procedures that have started. I know at my hospital, they've started, although I'm working in Charleston, the correspondence and talking to my colleagues, we have started elective medical procedures back. And so we have to continue to monitor what our hospital capacity numbers look like while we progress through and we open up and reduce these community mitigation strategies. We have to really keep an eye on how many more cases we're seeing and how many more hospitalizations and ICU admissions we're seeing in regards to being able to absorb the surge that we would potentially see if there is going to be an increase in cases. And then continue to ramp up the supply of PPE. I think this has been getting a little bit better, but certainly still significant challenges here all the time. Gowns, gloves, even masks. We obviously have talked about different efforts such as vaporized hydrogen peroxide to be able to sanitize masks and be able to reuse them. But we certainly need to continue to look for a supply of PPE and make sure that we're getting it to the individuals highest in need and making sure that individuals have access to it. If we want to expand our testing capacity, we have to make sure that we have adequate PPE to be able to do that. So there's certainly a lot of factors that play into that. And then the other part of the roadmap is ramping up our contact tracing capabilities. So Dr. Chris Martin, who has given a COVID echo before, and really the entire occupational medicine faculty have been very helpful in our efforts, and we're appreciative of such. But Dr. Martin, myself, a member of the National Guard, and Joanna DiStefano, we actually are leading a contact tracing course that's being offered through the WU School of Public Health. It's open to volunteers, as well as there's going to be a course credit option that starts on Monday. We are excited to report that we had our first cohort go through the didactic portion of this. It's about 15 hours of content that has different requirements, including lectures, assignments, quizzes, to what we believe would give individuals a good baseline of exposure to contact tracing. And we had 98 people in the first cohort. I think as of today, we had about at least 60 to 65 that had completed all of the requirements that were set forth in the course. Some people just took the course to learn, which was fine too. But we're now in the phase where we're going to be working with DHHR to get those contact tracers into the field. That course is just a small part of a larger contact tracing effort taking place in DHHR that involves getting a remote option capability that perhaps contact tracing could be done remotely. In addition, bringing on more staff members and more epidemiologists as a managerial level to be able to support these robust contact tracing efforts in our communities. If you go ahead to the next slide. To really begin the process of the comeback, the parameters that were set forth was that West Virginia needed to stay below a cumulative statewide positive test rate under 3% for 3 days, which was achieved during that time period. We are continuing to monitor the cases in this reopening process in the event that if a positive rate surges, then we may have to slow or stop or even pull back some of the efforts. It's my understanding that very soon we will be getting more information from the governor regarding his plan to do so. We've propose some ways which we have kind of determined to be an alert system that involves very aggressive monitoring at the county level, including that robust contact tracing, and that if we are seeing an increase in cases in a certain community, we have a task force that meets with that health department and community members to identify where are their cases happening, where are we seeing it, is it in a facility, is it in a community spread, what is really going on, what kind of resources need to be deployed to be able to help that community address issues, and then make further public health recommendations and actions based upon those discussions. So, you know, this is kind of what's been reopened, but certainly there might be areas of the state where we see higher transmission, and that those areas need to continue to have more stringent restrictions. And so I added this comment in because I think we're seeing this in the healthcare field. You know, these are recommendations, they're not requirements for reopening. And I've heard a lot of patients from my colleagues say, you know, we're opening back up, but some patients are still reluctant to go out because they don't want to take the risk to go out. And so, you know, these are recommendations to reopen, but not a requirement. If you go ahead and move to the next slide. Thanks. So this was kind of this was based upon this morning. This is the West Virginia cumulative test positive. So I drew kind of the line at 3%, but you can see that really since that time, our cumulative positive rate has stayed below that. Now this is a statewide cumulative rate. So we do have teams, it's a really impressive group of epidemiologists doing work behind the scenes that I get to witness at the state level, and it also happens at the county level, looking at, you know, rates within their communities, and if we see areas that have higher spread, because certainly in a state as broad as ours, we still, as this morning, had 3 counties that had no identified positives cases, but you know, we continue to want to monitor individual as well as statewide data. So if you go to the next slide. So this is where I think it's really important that as healthcare professionals, we continue to emphasize this. You know, just because we're opening back up does not mean the virus is gone. I think that we're going to need to continue to do those aggressive contact tracing and testing measures that we discussed. But we still need to be practicing social distancing, maintaining that 6 feet of separation between individuals, wearing face coverings in public, which I think has been one that has certainly come under more debate or discussion, at least on the social media channels that I'm on, and really, you know, saying it's not only protecting you, it's really protecting the person next to you or your loved one. So it's really being part of this community. And then follow the safer at home order that the governor, so previously we had a stay at home order, now the order is safer at home. And then also following county health department's regulations, because as I discussed, it could change depending upon where you live in our state, and that it was still encouraged to telework when possible. So if you go to the next slide, this is just basically the schedule. So we're currently in week 3 of the comeback. And there's the link that if you want to go to governor.wv.gov, the comeback, or just Google West Virginia comeback, and I think you'll be able to get there. So if you go to the next page, this is kind of just the outline of where we've been. So in the first week, it was medical procedures, daycares, although there needed to be enhanced testing, and then outpatient healthcare operations that were regulated by their licensing boards. In the next week, small businesses, as well as restaurants and outdoor dining, religious entities, and then barbershops, hair salons, nail salons, which I'm sure many of us are perhaps excited to see that. But again, in all of these places, they still have to be able to maintain those social distancing requirements, face cloth coverings, and the other infection control measures that we have been talking about throughout this entire pandemic. And then if you go to the next slide, this is the week that we're currently on. So we're talking about wellness centers, drive-in movie theaters, and then effective tomorrow is outdoor guided fishing. And the governor continues to announce different parts that he will be opening up in regards to, he talked about the Hatfield McCoy Trail that will be opening in the next kind of week layout. And I really encourage everyone to go to the governor's page, bookmark it, I have it as such, to get guidance as to what's the next step of what's being reopened. It's the reopening takes into account many different advice from experts, consultation, looking at where the disease seems to be transmitted in our communities. So there is a lot of input that is given, and it will depend upon where we see our caseload change as we start to reduce some of these prior mitigation strategies. If you go to the next slide, we'll transition to testing, because I think that this is an important part to continue to emphasize. So next slide. So we really are working to expand testing across the state, and this is being done both through private and public opportunities. So getting supplies from the federal government, but then also working with facilities to develop their own diagnostic testing. So for instance, WU, from what I'm told, is very close to launching antibody testing at their facility. They've been doing PCR testing, and when there is testing at the facilities, the turnaround time is much quicker than a send out, just for common sense purposes, that the specimen does not need to be transported. And then we still are referring to the CDC testing priorities when their supplies limited. But what we're going to be seeing as soon as tomorrow or this weekend, we're having community-based testing screening in high-risk populations. So where we've already seen this occur is testing in our nursing homes, and then more recently, we've now, the governor ordered testing in assisted living facilities, as well as daycare workers, so individuals who especially have high risk. And then really, we're making a statewide a concerted effort to really reach out to minority communities, because as we've seen more data, and this trend follows nationally, in some communities in West Virginia, there has been higher incidence amongst minority communities of disease transmission in certain counties. And so really there's a concerted effort in communities where that's been seen to try to increase our testing of minority communities. And I know there's at least 4 counties this weekend that will be having community-based testing events for anyone, but with a special emphasis in outreach and working with different community leaders to really focus in on minority communities. And so we think that this will continue to expand as our testing capacity expands, as we have more acquisition of rapid test, Abbott test. Initially our supply was small, and we never really knew when we would get more supplies in. That supply chain is improving at a national level, and as a result, we're starting to see more product come in on a more consistent basis at the state level. I think it's been discussed in prior echoes. Because we've had lower numbers across the state, we have at times not been really targeted to receive this from a commercial entity. So there's been some commercial companies who just quite frankly would not sell to West Virginia. In those situations, we would use all of our connections, including working with our congressional delegation, to advocate that just because the disease is not here, we're not seeing high numbers now, we have the highest risk population, and we need to have access to testing to determine where it is in our community, and so that we can hopefully continue to prevent low number of cases. And so again, we're going to continue to have strategies that work with multiple labs as more commercial options become available. So next slide, I'll just briefly touch on nursing home testing. This is kind of updated CDC guidance, I think, based upon at the end of April, and Troy may have touched on this, last week as well, that really, a test-based prevention strategy would be a point of prevalence survey. And so if the testing capability allows having a facility-wide point of prevalence survey of all residents. And so this is done as to try to identify early disease or asymptomatic disease, so there can be more aggressive infection control measures put into place to help further reduce transmission in those high-risk settings. So if you go to the next slide, Caitlin, we were actually the first state in the nation. We actually had a team from CDC here. And, quite frankly, when we were developing, I mean, there were questions are like, how are they going to do this? Do they really, there was literally the question, like, do they really think they can do this? And within 2 weeks, and this was a concerted effort of the West Virginia Healthcare Association, as well as local health departments, communities, as well as the facilities themselves, we were able to test all residents and staff within 2 weeks. That data is now available on a tab on the coronavirus.wv.gov dashboard. The full results are going to be released in tomorrow's press briefing, so I will leave that cliffhanger for you all to get that data tomorrow. But we are proceeding with a new executive order that is targeted at assisted living centers as well as daycare staff that are currently underway. All of our assisted living facilities in the state, some already complied with the prior executive order because there's assisted living centers within nursing homes. But as of yesterday morning, all of the assisted living centers in the state had a plan to perform testing, and that's projected to be done over the next week, and then we will wait for those results to come in as well. If you go to the next slide, I want to transition to my last point, which is Remdesivir. I think it's a little bit of maybe setting us up for the future as well. We all, I think, have been desiring a treatment or therapeutic, that will help us in treating this disease. It's a very interesting virus. I'm not an infectious disease specialist, so we'll allow the experts on the phone to speak more to that, but just how this virus seems to be changing and how we're learning more about it. It is certainly caused a lot of, I think, intellectual curiosity, and just it's been fascinating at times from an intellectual standpoint. But one of the new therapies that we are now seeing being used is Remdesivir. So if you go to the next slide, it's a direct acting antiviral drug that inhibits RNA synthesis. So it's a nucleotide analog that really inhibits viral RNA polymerase, particularly when seen in animal models, and then also being used more so in other MERS and SARS cases, and now with SARS-CoV-2. And so the initial placebo-controlled trial, the preliminary data reports a faster time to recovery. So if you go to the next slide, we saw in the preliminary results released that the days to recovery decreased from 15 to 11 days. So that's a statistically significant variable. The mortality did improve, but wasn't quite significant. However, the Data and Safety Monitoring Board halted that based upon the positive trend. So on May 1st, the FDA did approve emergency use of Remdesivir for patients with suspected or confirmed COVID-19 with severe disease. So if you go to the next slide, prior to this week, no one in the state of West Virginia had been able to get this medication because it was only available for compassionate use through clinical trials. From talking to my colleagues, there had been many individuals who tried to get this medicine but were unable to do so. On Saturday, we were informed as a state that we were going to be getting a shipment of this supply. And then on Monday, so let me step back. We weren't told when it would come. We were just told that we would be getting it sometime within the week. And so on Monday, we were notified that our initial shipment was en route, and that arrived on Tuesday. So the Bureau for Public Health has been working with local and state partners to develop a distribution plan to hospitals throughout the state that will be able to comply with an executive use authorization. And so a team of clinical experts with representation across the state is simultaneously creating a statewide clinical protocol for criteria of use in the clinical setting, so that we recognize that this is going to be a very scarce resource. And so we are developing strategies to ensure that it can be as equitably distributed as possible, and that we get it to the patients that are in need. I will mention on this call that it's very important to make sure that our hospitals are updating how many patients are hospitalized and we're treating for this, for COVID-19, because that is how the federal government is basing its distribution plan off of, is based upon how many hospitalized patients we have. And so we were just notified, so this is the new information before even I could update these slides. We were notified today that we have a second shipment of Remdesivir that's on its way to West Virginia. So it's not, you know, obviously it's again a small supply, but we'll take whatever we can. And you'll be hearing more about the supply distribution, as well as the clinical guidance or the clinical protocol for Remdesivir in the very, very near future. So if you go to the next slide, I just wanted to say thank you. This is a picture I pulled out from our Let's Go Gratitude project that we're working on, where they're going to a doctor party. The child who submitted it says doctors need to have fun too, even while they're keeping us safe. So I will just say thank you to everyone on this ECHO for the work that you're doing in your communities, and that you do all the time, but certainly now in this pandemic and moving forward as we continue the phase of the comeback in West Virginia. So thank you so much, and happy to address some questions.
Thank you. That was wonderful. We super appreciate your time on that. We definitely did have some questions come in, and also we had some resources shared on the chat. So everybody, you know, of course, check that out, and we'll send those out after. So a story about the first patient who received the Remdesivir in the state was at Princeton Community. That's really cool. And thank you, Jared, for sharing that link as well. So one of the questions was, if telework is still advised when possible, is telehealth still advised when appropriate? If so, will it continue to be reimbursed?
This is an excellent question, and at this time, there's not been any discussion to stop the payment of services for telehealth. And so that gets brought up on our virtual town halls. So in discussions with our Bureau for Medical Services, I think the West Virginia AFP brought this question also in a meeting we had with providers. At this time, those services will continue to be paid for in telehealth and telephonic means. And I think that it is ongoing encouragement to engage in that type of work when needed. And Clay Marsh was on a town hall, and I think brought it up and kind of opened up for discussion. I think from this, obviously, we've learned a lot about improvements we need to make across the board in our public health system and our healthcare system when there's something of this magnitude. But I also think there's been some positives as well that we've identified, whereas what we were able to do in a 2-week time frame, really in the realm of telemedicine, we had not been able to do in a 2 to 3 year time frame. And there's many patients and providers who have indicated how they feel it benefits their practice. And there was a story shared from a family practitioner. They did an ADH check. The patient was at home with grandma, the mom was at work, and the dad was at work, and they were able to actually have a visit of them all there together. Whereas if the child would have had to come to the clinic, it would have only been with the grandma, and it was a much more fruitful and more productive discussion because they were actually able to get input from multiple members of the family. There was another example of a patient, you know, being in their bulldozer at work, going to their visit. And so I think that moving forward, we'll see telemedicine and telehealth be more integrated into our practice. I know from an education standpoint, they're looking at making a potential telehealth thread, or making sure that telemedicine is at least offered to our students, because we all had to adapt our clinical practice to deliver care in that regard. Some were already doing it, others had to really learn quickly. So at this time, those services will continue to be paid for. And at least in my last discussion, which was just last week, there really has not been a defined time as to when that would cease. And so that information would obviously be communicated to providers, but for now, it's still encouraged to do those type of visits where possible. As a pediatrician, I would make a plug. I just came off of a call before this about the importance of immunizations. Nationally, we have seen a decline, as well as in West Virginia. When we compare last year's numbers to this year's numbers, there's been a pretty significant decline. I'll have to look for the specific numbers, but it was a significant percentage of a decline even within our state. So there are certain things that we need to be encouraging individuals, particularly children or parents, especially as we move into the summertime, where we would usually see back to school physicals and sports physicals occurring. We need to make sure that people are still getting their immunizations so that we can protect and prevent diseases that we have a known mechanism to prevent. We don't want an outbreak of measles on top of a COVID pandemic for multiple reasons, but we need to make sure that we're still encouraging those good public health preventions in other capacities as well.
Yeah, definitely. Thank you for throwing that out there as well. And it's super encouraging to hear about the telehealth efforts. So right along to the next question, will the expanded testing for minority populations include documented and undocumented immigrants, especially those in the meat plants?
So this is a great question, and the goal is to really target all minority communities, and there have been testing opportunities to try to reach those populations that were mentioned, as well as all minority populations, including making sure that there's translation services available, particularly for undocumented immigrants, where there may likely be a communication barrier. And so, there certainly wants to be efforts in there. This is where that community partnership, I think, is really important, and those locally to really know their community, and our health departments have been doing a tremendous job to reach out. And so my understanding and the effort is really to try to encourage all really community-based testing, but to hone in on minority communities to get the word out and encourage testing to occur across the board.
Thank you. So we had another question. We have several questions, so I'm just going to shoot them out. So although the cumulative % positive case is good for the initial wave of infection, as time goes on, will we be switching to a different metric? For example, R number, 5-day average, incidence curves?
Yeah, so thank you for the question. Excellent question. So the press conference is scheduled for 1, and it's my understanding, I've been working on our Remdesivir clinical protocol guidance this morning, as we certainly want to make sure that we get that rapid turnaround out. But my understanding is that you will be seeing a proposed mechanism that would be monitored, and it does take into account county level information. So we've had a few discussions with our local health officers and local health departments as to what's the best mechanism to do that. And we've been doing data analysis really over the past week to identify kind of what your question gets at, is what's that time period? Is it, if we see you go up in one day, if we would put measures in and then the next day you're back down, like that doesn't really make much sense. So we need to, we're trying to determine, what are we seeing? Is it a consistent elevation in case numbers that have occurred over a period of time, and then working with the local communities to determine what's really going on at the local level, making sure there's proper contact tracing and testing resources so that individuals are getting tested to really determine what's the spread in a community. So you'll be hearing more about that. My understanding is later today that does detail out more so how individual communities would be contacted. I know Dr. Marsh really uses the R naught a lot, and I think Dr. Hodder could probably speak to some work happening through the CTSI about how we can do better mapping and projections across the board as we learn more. But it all kind of goes back to that testing and contact tracing as well. If we want to make these projections, we have to have a real true representation of what's the prevalence of the disease in our communities. I've shared, I think, what I can share without stealing more from, I think, what the governor's going to announce here in just a little bit. But our hope, or the design and the public health thought of it, was we have a very diverse state where we have some counties that have very few lower population, then we have some counties that have a much higher population. And so we did have to look at the data of what it would be at a community level, because there is a difference based upon where we're seeing higher incidence of disease right now, and what those numbers would mean if you're talking about a small rural community. Like I said, we still have 3 counties that have not had any cases reported yet. It will be a approach that's outlined that takes multiple factors into case, including kind of the positive case rate.
Thank you. So another question. There's a weird association that's been reported with communities with high rates of MMR vaccine utilization have low rates of COVID burden. Could anybody comment further? Is that anything anybody else has seen?
Well, thanks, Dr. Peters, one of my favorite residents when I was a medical student. I think that I also just recently saw an article out about this. I'm not quite sure yet, if there's any true association or why that would be the case. And I think it'll just take a little bit more time to determine. Last week, Dr. Hodder mentioned about commenting on PIMS, or this Kawasaki that we're seeing in children. It is fascinating because really, to my knowledge, we had not really seen reports of this coming out of other countries. However, since it's been being reported more in the United States, I think I just recently saw Italy has been seeing an increase of that type of inflammatory response there. And so I think certainly in the pediatric population, still by and large, kids seem to get mild disease, but we are seeing, particularly in New York, where there's been an increase in this PIMS as well. So I think time will tell, but yeah, it's a good question about the vaccine utilization rates. I recently saw a piece on that. I didn't get to dive very far into it. I'd yield to any wiser, more, individuals on the call or the meeting that might be able to speak to it, if anyone else knows more about that particular comment.
So I am certainly not wiser, and I am unaware of those data, but I did want to sort of just make a comment. Lisa really talked about immunization in the context of visits. And one of the concerns is that, subsequent waves of COVID-19 may occur in the fall and overlap with influenza. And you can imagine, what an impact this would have on the medical system. And so whereas possible, they're really trying to get the influenza vaccine out early. And I would say this summer, I think that we really need to make a push to really make sure folks have influenza vaccine. Not that it will protect against coronavirus, I want to be very clear, but hopefully it will provide protection against influenza virus, a different virus. And I think that that will help to at least prevent some overlap, with a large burden of infectious disease. So that was one comment. The other comment that I think is fascinating is what Lisa said, and that is that, sort of this Kawasaki-like syndrome, for love of a better word, seems to really be a phenomenon mostly reported in Western Europe and the US. And whether that is a genetic underlying predisposition, whether it is changes in the virus, and there have been mutations described, though I would suggest the significance of those has not been really delineated. But, or is it just a reporting bias that people are seeing it in the West and, it really wasn't seen in China? I don't think we know, but I think every week we're learning something new about this virus. So nothing surprises me anymore.
Yeah, I think those are excellent, excellent comments. I do think, I didn't really talk about this, I do think that there are preparations or concern that, there likely will be a second wave, and we need to be prepared for that and be prepared for the possibility that it would be worse than this first one. Just speaking in my communities that I've been in, and I'm in Charleston right now, primarily working. My husband lives in Morgantown, and we both talk, and I mean, it's clear that there's more people out and about. I think there's less people probably wearing the face cloth coverings than I would like to see, but this is a cultural shift. I think in Asian cultures, they went to wearing face cloth coverings after MERS and SARS before, where that has not yet really been a culturally acceptable thing here in our communities. So it really is going to take time to get buy-in, I think, and showing that we feel that that's a really important strategy to reduce transmission. But yeah, I think we need to still be encouraging those other public health interventions, such as flu vaccines and immunizations of what we are able to prevent.
Absolutely, thank you. Excuse me. So you kind of just touched on the next two questions are very similar. One of them is more broad and one of them is a little more narrow, so I'm going to give you both of them together. The first is, if a second wave were to occur, do we have a theoretical West Virginia guideline for how we would respond to that? And then the second is about daycare workers. And so with regard to daycare worker testing, there was a positive case in a worker in a daycare that has been open as crisis childcare center for about a month. The individual tested positive, and she was a teacher who has direct contact with at least 5 children. Per CDC recommendations with regard to contact tracing, these contacts should be advised to stay home until 14 days after their last exposure. Let's see, in the case of all of the children, all 5 were allowed to return to daycare Monday this week without any testing. This seems like it could lead to more disease spread. Any thoughts on how this should be handled, especially if further testing of daycare workers will continue?
All right, there's a lot there. I'll try to pick them apart, and I am seeing them as well, so I'll try to hit on those. So I think the first question was, if, in the second wave, is there a plan to address that? I think, obviously the answer to that is that certainly there are ongoing plans being developed. Unfortunately, I think as Dr. Hodder said, and as I've said, things change literally at times, it seems hourly, still, maybe not as to the level it was in the beginning of this pandemic, but there are certainly ongoing changes. So it absolutely depends upon what we see. I think in our state, it's hard to predict what's going on in other states. And so we are a significantly bordered state just based upon the geographic nature of our state. And so if you look around us, there is still a significant amount of disease in certain areas. And it's hard to project that to a certain level. I did some work recently in the Northern Panhandle and talking to people on the ground there. They were saying the majority of their cases that they were seeing in their hospital was from Ohio. And I think the Eastern Panhandle could report the same, as in other bordering counties would say the same. So I think that's why when you go back to one of the first slides I presented with the roadmap, we really need good testing and contact tracing in these communities to be able to identify, if we start to see an increase in disease, what can be actions that are taken maybe more at a local level versus more widespread disease. And then I do think we need to be cognizant, and there's planning, like I think, again, a great point Dr. Hodder brought up about flu is if we are projecting additional cases in the fall, this pandemic kind of hit at the end of flu season where we were seeing flu cases. But if we, are expecting, because, although vaccines are in development, I don't think there's really, again, any indication that we would have one this year, that, we might see the next wave kind of coincide with maybe the beginning of flu season. So we would have to take into account hospital surge capacity, dealing with those respiratory illnesses. As a pediatrician, obviously, RSV, I mean, we had a serious RSV season, at least in our hospital, particularly around New Year's. We were incredibly busy. And so when you're talking about healthcare utilization, so I think that those plannings need to continue, and they are at a state level, but also really at a local level and a hospital level, that there needs to be ongoing preparedness and planning, because it may change depending upon where we see those increase in cases. So to transition to the daycare worker test, so just today, you'll be seeing there's actually daycare center guidance for outbreak management. As Troy discussed, or Dr. Krupika discussed last week's ECHO, the outbreak definition in West Virginia is if there's 2 positive cases would then be determined as an outbreak. And so I don't know specifically which facility is referring to here, nor would I perhaps have that information. But based upon the investigation that would happen for that positive case and the contact tracing, they would identify who would be determined to be at high risk. And then if their contacts, there have been discussions in similar capacities like healthcare workers in regards to, would you have individuals return to work? We had multiple conversations with childcare facilities as well as our outbreak staff when we were coming up with this guidance. I was trying to find it quickly to see if I could have I don't have it handy for the sharing of this, but I can make sure Caitlin has it to disseminate that approval of the child care guidance that speaks directly to what your question gets at. Again, I don't know the specifics of that case, but I would say based upon the case investigation and the contacts, the determination that would have been made would have been incongruent with consultation of the local health department as well as the state team guiding recommendations for those centers. But certainly want to make sure that they're following good infection control. And I think we don't want to lose sight of that, is that we still need to be performing good hand hygiene, not touching our face, wiping down our surfaces, maintaining that physical social distance of at least 6 feet, and wearing our cloth face coverings. Still staying home if we're sick, things like that during this time and moving forward.
Thank you so much. That was a lot. I appreciate it. Okay, so 2 more questions now. Are you aware if there are any special impact of the virus on youth with well-controlled type 1 diabetes? Are these youth considered high risk?
Great question. So to my knowledge, and if there's pediatricians from other parts of the state, but one of my roles, I get to the honor really of being the president of the West Virginia chapter of the AAP, and my role is a peds hospitalist, so I care for kids in the hospital setting. My group at W, we have not had a admitted positive pediatric case. And from my discussions with colleagues around the state, they have not required hospitalization either. I'm not saying that they haven't been evaluated, but they have not required inpatient hospitalization. In West Virginia, as of this morning, 4% of our cases, which is up to 1427 is what I think, when I just looked at the 10 a.m. update, yeah, 1427 is our most recent update. Still 4% were lower or younger than age 19 from a percentage standpoint. So at least in West Virginia, we're still seeing a lower number. Nationally speaking, in regards to if there's higher risk populations, I think anytime that someone's immunocompromised, we're still being concerned about that. And so I think we want to make sure that we're just cognizant of that, that if they perhaps were getting symptoms, or in the case of type 1 diabetes, just like you would do in management of any sick time, making sure that they're receiving the proper care. You know, I think that they kind of fall into that, I guess, higher risk subpopulation, but really across the board, we continue to see children get mild disease if they contract, you know, SARS-CoV-2. So it's a good question. I think a little bit time will tell, but unless anybody else has any more things to chime in, that's my current understanding of that. And we hope that that remains, but again, we're learning more and more about it all the time.
Definitely. If anybody else does have information or resources you'd like to share to help, you know, answer some of these questions, you're welcome to email me or I, and we'll send those out along with everything else. So we had kind of a clarifying question. When speaking about disease and increase in disease, does this mean new cases? Does it mean hospitalizations or ICU admissions? These mean different things, and trying to figure out how to clarify that.
Yeah, so I'll take a stab at it. So I think when I talk about new cases, I certainly talk about new positive cases. And the assessment that occurs is in all of those situations. So are the positive cases occurring in an outbreak setting? So is this a nursing home or an assisted living facility where we're seeing multiple positives in that facility? I think we're still discussing, and there's, you know, debate when you're talking about staff members who may work in that facility and they're positive and then they go into their community. And then are those cases, you know, does it then further lead to community transmission, which is again, the emphasis of why we need good case investigation and contact tracing. But then also when we're talking about hospitalization or ICU admissions, this is information that's been reported by our hospital system. The West Virginia Hospital Association has been a great partner, as well as the hospitals themselves, because we get that everyone's having to report a lot of information, but it does make a difference. Like when I talk about Remdesivir allocation, it goes down to how many hospitalizations of hospitalized COVID patients we have. In our state, I think it's challenging, and I can't speak to all the centers at this moment, but anecdotally, when I was at Wheeling a few weeks ago, I think they had like 8 admitted COVID patients, and they told me like 7 of them were from the state of Ohio. So when you're talking about our case counts, the cases reported based upon the zip code of the patient. So sometimes our healthcare system may be utilized by out-of-state individuals. The same goes for us as well. There could be West Virginia residents and other state hospitals as well, so utilizing other state resources. So I think that we'll need, there's analysis and monitoring of all those parameters, because they do mean different things. If obviously we're seeing a higher increase in hospitalization and ICU admissions in a certain area, looking at their surge capacity, where are those patients coming from, what can be done to try to help mitigate transmission or spread is really important. I would be happy to yield to anybody else on the session if they have anything else to add in that regard, people working in the hospital setting. But that's what we mean by cases. So a positive would be a case, but then further looking into that of where is it happening? Is it happening in what setting? And then at the same time looking at cases in hospitals and ICU admissions, because again, those might be coming from places other than West Virginia.
Definitely, thank you. And so when saying 2 positives is an outbreak, is this in any setting or only in high-risk settings like the nursing homes?
So great question. I think Dr. Slemps and Dr. McCann's echo kind of touched on this of the outbreak definition. It is more so describing in the setting of a congregate care setting. So whether that be a nursing home or a residential treatment facility or, you know, a daycare or something like that. It is talking more about area where there's individuals that are more congregated together. So thanks for that clarifier.
No, thank you. Perfect. Everybody, we have about 5 minutes left, and I think we have 2 questions, so we're all set. We're good. But do false positive cases get removed from the data?
Dr. Sawari, this is a great question, and you're a much smarter person than me. So what has been the challenge is, how do we truly determine what is false positive? You know, and we've seen in our testing where there have been cases identified as positive, the patient is asymptomatic. There's not really other spread, as we have seen usually in nursing home, using nursing home as an example. You know, in nursing homes where we've really seen disease, we have more so seen transmission amongst the population, whether that's staff or residents. And so in some of these cases where there might have been a case where someone tested positive and then there's subsequent negatives, when you go and look at the actual test itself and the number of cycles where there's virus detected, there's still virus being detected. Now, one could argue, is that viable virus? Is that, you know, cross-reactivity? I think it's a challenge as we learn more about how to apply serologic testing, and as those tests become more valid, that we could have somewhat more confirmation in a short-term period. But to date, to answer your question, the false positive cases haven't so much been removed, because I think at this point, it's still been, if you're a positive case, you're positive. I think what we've talked about is that if you have a positive case, but clinically or epidemiologically speaking, it doesn't make sense. You know, clinically speaking, they've never had any symptoms, but although we know that there is asymptomatic spread and subsequent testing has been negative, then maybe we would adjust our clinical guidance and say perhaps they were at the end of their exposure, or because they're no longer testing positive. So it's an excellent question, and I think with any test, there's always some level of false positivity, but thus far at a state level, that hasn't per se been removed. I think we're still at the process where we're looking at getting subsequent testing in some of those cases, including serology, to see what we find, if there would be a true determination of, is this test truly a false positive? Hopefully that answers your question, but I certainly would also welcome your expertise or comment on your thoughts of that as well.
Thank you, Lisa. I think I was asking this question primarily from the basis of, you know, we are fortunate, we are a low prevalence environment. And by the very nature of testing, however sensitive the test may be, when you do it very often in a low prevalence setting, you will see false positives. And by that, I mean true false positives, not the asymptomatic person who tests positive. I mean somebody who does not have the virus and tested positive. And clinically, we have had that happen with the last 4 or 5 that we had unexpected test results on. You know, setting of a closed environment with no egress, and everybody's negative except for one person, and that person tests again and they're negative. So I think you are right. As we go further, for the accuracy of our data, we might need to think of a mechanism of how to deal with this.
Definitely. And thank you, Dr. Sawari. So we're
Yes, I
gonna,
would just say, I think the decision would be to remove that for, like you're saying, the data. I think it's still, hopefully, maybe by the next time we have an echo, we would have that further kind of identified, particularly as we start to see more antibody tests come on board and antigen tests come on board down the line. But I think it's a great point, and I appreciate the additional comments. Sorry, Caitlin.
no, please. I just wanted to say we're going to hold the last question for our next session. That should be fine. I wanted to make a couple of announcements. We're here down to the minute. So our next session is going to be June 4th. We're going to have a 2-week break. And I want everybody to give input, so feel free to email if you guys have questions, comments, or thoughts on topics. We are working on planning further sessions, but right now we have June 4th and 18th planned. For anybody who's been missing Hep C and HIV echoes, then we're starting that back up on the 28th, so there you go for that. And Dr. Martin is going to be here on June 4th. He's coming back and he's going to discuss vaccinations with us. You'll remember he spoke about testing a couple weeks ago. And then Dr. Hodder, I just wanted to give you another second here at the end.
Well, no, this was great. Lisa, thank you so much. Thanks for everyone for your questions and comments. And we'll see you in a couple weeks. If there's anything we can do in the meantime, you know, contact Mitra, Jay, Caitlin. You know, we post the questions and so forth, and we're happy to find an answer. So thank you. Stay well.
Thanks, everyone.
Thank you, Lisa.
Take care. Stay safe.